Bismillahirrahmanirrahim. Today we are going to have a discussion on Ramazan and heart patient, and basically do and don'ts for a heart patient during Ramazan. So let's start today's discussion. And what I'll covering in a way that our flow would be that I'll divide different categories of heart patients and then present in front of you those patients to assess what should be done for each individual. And let's see, I'll be starting with a common case scenario, and with a common kind of patient which we see in our daily routine practice. And before that, I would like to say a few things about Ramazan and heart disease as well. So first, I'd like you to concentrate on this scenario, which is a very common scenario we face in our daily routine practice. 60 years male, known hypertensive, had acute myocardial infarction 3 months back through angioplasty, went through angioplasty and stenting, presently symptom-free on routine activities, and he's taking his routine medications, which are usually dual antiplatelet, ACE inhibitor, beta blockers, and statin. And he's inquiring about fasting. Now, usually what we do in such patients, a casual advice is given that no, you can't fast. You are an old age and a heart patient, so you should avoid fasting. But actually, that's not the case. You have to judge each individual very carefully for that. And I would like you to know why it's very useful, why it's very important to judge every patient. And in this kind of patient, whenever you are asked to judge, you have to answer 3 questions after judging your patient. Can he fast or not? That's the first question you have to answer. Second, if no, will he be able to fast in future or not? That's the second. And third, if you are allowing him to fast, if yes, what precaution should he be taking? It's very important 3 questions. Why is it important? I started with this slide, which I deliberately omitted, that I'll discuss after scenario and after the objectives of assessment. That's a very important ayat, which is saying, वमन कान मरीज़न औ अला सफ़रिन फ़इद्दतुम मिन अय्यामिन उख़र, और जो शख्स हो बीमार या सफ़र में तो तादाद पूरी करे दूसरे दिन. That means if you are prohibiting someone from fasting because of illness, then you should be very clear with, will he be able to fast in future or not? It's very important to judge, because in that sense, you have to advise that how many rosas he can commit and then be able to fast, or whole of the Ramazan he can't fast, and when he will be able to fast again to complete the counting, or he will not be able to fast so that his relatives would think of giving fidya for that. That's very important thing. So that's why I'm saying that whenever you judge a patient with heart disease or any other illness, and this question comes to you to judge, you have to answer these 3 questions. Can he fast or not? If no, will he be able to fast in future, and if so, when? Third, if you are allowing him to fast, and that's a very important point I'll cover in my presentation, if you're allowing him to fast, then what precaution he should be taking. So what I do, I'll give you a broad, you can say, guidelines towards cardiac patient, that how to judge whether your patient can fast or not, and what are the bases on which you decide. Ideally, it should be an individual basis or individual characteristics which are really helpful to make a decision regarding whether your patient can fast or not. But what I do, I'll give you a broad guide or broad steps to judge that if these things are there, then you can clearly say that this patient can't fast. And these are the things that are there with the cardiac patient, then you can say, yes, patient can fast. This is a very important slides of mine. I have classified the heart patients into these 4 categories: ischemic heart disease, hypertension, heart failure, and structural heart defect. Now, actually, these classification, you may got these patients as a separate entity, or maybe a combination. Let's start let's start and take every category one by one. Now, if we start with the ischemic heart disease patient, which is the first category here you see. So in this ischemic heart disease patient, a patient with acute coronary syndrome, this patient can't fast. What I mean to say acute coronary syndrome is acute ST elevation MI, acute non-ST elevation MI, and unstable angina, ongoing pains, patient needing multiple sublingual angiosit during even on treatment. And you have different kind of patients in ischemic heart disease basket, even the stable IHD with very severe symptoms of instability. So these are the patients who can't fast. And on the other side of spectrum, your stable IHD patients who are asymptomatic on your medical treatment, they can fast. Now the important is to decide when acute coronary syndrome converts into stable IHD. A patient who had an ST elevation MI after 2-3 weeks, if he's uncomplicated, no issues occur during, and his LV is normal, even if it's LV normal, he's a young patient and doing well on medical treatment, having no further symptoms of SOB or chest pain and needing no sublingual, and they said no further workup required, and this patient usually stabilizes within 2 to 3 weeks. And then this all depends on each individual characteristics, the status of other comorbidities your patient is having, along with this event, and then you will decide. Similarly, let's come to the second category, which is hypertension. Now, in hypertension, if your patient is suffering from hypertensive emergency, and when we say hypertensive emergency, this is a patient who's having very high blood pressure with evidence of ongoing target organ damage, a recent event or during that. And with that, you have to convert him to stable, mild to moderate hypertensive, meaning by, now this condition is not the kind of condition which remain persistent for a long. So if you take care of his additional comorbidities like pulmonary edema, severe ischemia, stroke, renal issues or other, and after taking care of all those, your patient on drug is coming towards stability, and he's having no more symptoms of the additional complication as well as of having high blood pressure, is doing well on your blood pressure medications, then he can fast. Similarly, now coming to the third category, which is a heart failure patient. A heart failure patient having ejection fraction less than 40%. The reason for this heart failure patient may be ischemic heart disease, maybe hypertensive heart disease, or any other reasons like peripartum cardiomyopathies or adult cardiomyopathies. These are a kind of patients which, if they are severe symptomatic, meaning by having severe resting shortness of breath, and they have rhythm issues, they are hypotensive, in shock, but that's the state that they're always, along with LV dysfunction, having severe symptomatic state, and these are again kind of patient which can't fast. But if with LV dysfunction, the patient is doing well on drug, is stable, his function class is normal, he is in NYHA 1 or 2, having minimal SOB, doing his routine activities, he can fast. Let's come to the fourth category, which is again very common, valvular and congenital heart diseases. Now, in this valvular category, you can have patients with severe symptomatic congenital or valvular heart disease. This is side of the spectrum, and these patients can't fast. It's a severe symptomatic, meaning by having SOB or maybe advised surgery by the surgeon, but they are not going through it, and they are very fragile or unstable. The slight disturbance in this routine, slight changes in hemodynamics make them symptomatic, and they can't fast. You have such patients, severe MR, severe AS, by surgery due to other comorbidities and not going through it. So then you can't. But if your valvular patients or congenital heart disease patients have structural heart defect, which is mild to moderate, and they're asymptomatic or minimally symptomatic on their routine activity, then they can fast. It's not kind of issue that are small or medium sized ASD and they're doing their job and other activities, but just for sake of fasting, you say that you can't fast. That's not the case. So overall, this slide is very important. Now the thing which really matters is that when to say that your patient is stable and when to say that he is in acute category. A lot of patients may be having a status which is gray. So that means before deciding a about cardiac patient, whether he can or he can't fast, you have to assess his clinical status, his category, and the stage of disease at which he is right now, starting from acute coronary syndrome to stable IHD, hypertensive emergency to a stable asymptomatic hypertensive, severe symptomatic heart failure or a stable heart failure, or that. Now, if you are able to judge by yourself that he is a category, and usually these acute categories are either in the hospitals or coming immediately from the hospital, that they had a history of admission 1-2 weeks before, so you don't have much issues in these patients to decide that they can't fast. Similarly, a complete stable patient, again, you don't have much difficulties. The key thing arises when your patient is borderline and is in between. And usually if you have this capability of judging a cardiac patient in terms of his clinical status and his future risk, both in relation to his disease status as well as a risk posed by prolonged fasting to this patient, and can decide that this fasting may be leading to a life-threatening complication to this patient, yes, okay, you can decide about that he can't fast. But what I personally suggest to a primary care physician or a person who's not related to that specialty, if you are able to decide that he can fast, that means you are confident enough to say that this patient is stable. This is okay for me, that if you are allowing him to fast. But if you are of the view that at present your clinical status is so that you can't fast, then ideally in this borderline patient or a moderate risk patient, you take an expert opinion from a cardiologist, because it's a big responsibility to deprive someone from a Ramazan fast. You can complete his count later on, but there will be no replacement for this particular fast which he's leaving and not really doing in Ramazan. So it's a very big responsibility. If you are able to judge the clinical status of your patient exactly, and there is no issue at all, then you can judge and decide when he will be able to fast again, and what things need to be done to make him ready to fast. So these are very big questions which usually need an expert advice. So that's very important. Now let's go to a subject that if you are allowing someone with different cardiac comorbidities fasting, then what things you will be looking for, or what precautions and what regarding treatment you are. Now let's first cover an IHD or hypertensive patients. This category of patients are usually post-MI, post-PCI, post-CABG and angina patients on medical treatment. And they are most of the time are taking beta blocker and ACE inhibitor, antiplatelets. बेटा ये दरवाजा बंद करो और आवाज स्लो करो, ये खोल के चली गई दरवाजा, तुम लोगों ने आवाज तेज कर दी, बंद करो जल्दी. बंद नहीं रहने दो उसको, रहने दो इसी का रहने दो, तभी वो बंद होता है. उसमें फोल्ड रहने दो और दबाव दे दो बस, हाँ बस, वरना खुल जाएगा. So when you are considering this, so what you'll do, that either the category of this patient needs to be that these patients should be taking their all medication regularly. What you have to do, only beta blocker, take the beta blocker in seher, and rest of the medication including aspirin during iftar. And when you are really making this these changes in medication, the important, check heart rate and blood pressure before iftar. That's very important, because that will help you to decide whether your morning beta blocker dose is just enough to control his blood pressures or it's over treating. So according to hemodynamics, you can change this scheme as well. Every individual will be behaving differently. So it's very important to check heart rate and blood pressure before iftar. If needed, reduce seher dose, meaning by your patient's blood pressure are reduced or low and he's feeling symptoms of hypotension, then reduce morning dose and divide it into two. So half of it should be given in the morning with sehri and half should be taken into iftar time. And if his blood pressure are in upper ranges, then you can take his ACE or ARB as well, half dose in the morning. And that's why I'm saying it's very important to ask these borderline patients and these patients on drug to have nafli rosas during this period before Ramazan. That gives you an idea that what kind of hemodynamic effects fasting is bringing on their routine. So you would be in a better position to advise adjustment in that. Now, regarding heart failure, same as that of IHD and hypertensive, regarding other medications, which we are talking about, antiplatelet, ACE inhibitor, beta blocker, statin, take all medication after iftar, and just beta blocker will be in the seher, and according to blood pressure status, you can up titrate or down titrate the morning dose. But in heart failure patient, the additional important point is the diuretic, which is very important. And what you have to do with this diuretic, that usually heart failure patient are taking diuretic in the morning. So as specifically advised that don't take this diuretic dose in the morning, keep it after iftar and after Tarawih. Then additional point, avoid excess intake of water and salt. This is again very important point to be mentioned to these patients, that don't take excessive water and salt. Because a number of times these patients after iftar, they take a lot of water, a lot of other drinks, sugar and all those salty things. So that should be avoided. And again, same applies to them as well. Check heart rate and blood pressure before iftar for titration of morning dose. Now, regarding patients category with structural heart defect, sometimes these structural heart defect patients are on beta blocker or diuretic or ACE inhibitor or ARB. So same strategy will be applied to them, just a low dose of beta blocker in the series, and rest of the drugs should be taken to the iftar time. With that, we have covered a broad category of patients with classification. So if I just conclude that what we have covered right now, that heart patients, what you have to judge each individual according to the categories: ischemic heart disease, hypertension, heart failure, or congenital or structural heart defect. Acute coronary syndrome, hypertensive emergency, severe symptomatic heart failure, severe symptomatic congenital or valvular heart disease. These patients can't fast. All stable IHD, asymptomatic and routine activity, stable hypertensive with mild moderate hypertension. Third, those who are having heart failure but asymptomatic, they can fast. And mild moderate structural heart defect patient, they can fast. So with that, we have almost covered regarding do and don'ts, and also the treatment strategies, what kind of treatment alteration you have to do in these patients, I already have covered. Now I'm coming to an additional point, which is again very important. And I would suggest all of you to take care of that and take this opportunity, the Ramazan opportunity, not only for your patient, but even for yourself as well. That Ramazan is an opportunity to bring positive changes in life. As we know that what is Ramazan and what is the objective of Ramazan, that ya ayyuhal lazina amanu kutiba alaykumus siyamu kama kutiba alal lazina min qablikum la'allakum tattaqun. That this whole exercise is to bring taqwa in our life. And taqwa is self-restraint from all evils, whether these evils are spiritual or physical, related to both health, spiritual or physical health. So this is a very good time for counseling, for stop smoking and step towards healthy diet and lifestyle, losing weight and obese. So every obese person should gauge himself before, during and after the Ramazan to check about his waist circumference as well as weight, what's happening to the weight. And the positive changes which he has to bring, which has direct relation to his physical ailment, his comorbidities, as well as even if he's healthy adult, that he should be aiming reduction in weight and bringing positive changes, that stop smoking and physical activity. And what are the things which we have to really follow? That in diet, usually our Ramazan diets are very, very much, you can say, rich in fat, in salt, deep fried things, sweeteners. So you have to increase vegetables, fruits, whole grains, low fat dairy products, fish, legumes, vegetable oils, and nuts in your diet. And oil should be as less as possible. Take more of a fibers, fruits and vegetables. Similarly, limit intake of sweets, sugars, sweetened beverages, processed meal, and red meat. These are just few tips for diet, which not only you have to follow, but try to make it a routine for whole of the family, that your stress should be on fruits and vegetables rather than fatty things and sweetened things. And regarding physical activity, I think we should be doing physical activity during Ramazan. And what is that? Modifying frequency and intensity of physical activity to our post sunset. That means after iftar. Ensure adequate fluid intake to avoid dehydration. But if you are a patient of heart failure, then you have to judge yourself, your functional capability, and then do the physical activity and water intake. Maintain normal daily routine activity, walking, stationary, cycling. Now, if performing Taraweeh, that will be a good exercise along with it. You should be, if you're planning physical activity and you're doing Taraweeh as well, then do your physical activity after Taraweeh and take a light meal after that. Or after Tahajjud prayer prior to Seher, that you can again do. So that's very important, that not do exercise just before iftar. A number of people do that. Avoid that. Don't do exercise just prior to iftar. So with that, I am coming to the conclusion or the last slide of my presentation. So the conclusion is that carefully assessment of disease status is needed in every patient. And in every individual decision should be made according to the pros and cons. Real problem arise in a moderate kind of patient. And especially if your patient is very willing to fast, then you can be helping him to go through fast by adjusting the medication, keeping him in a close contact of yourself and advising him to do at least go through 2-3 Nafli Rosas to judge his capabilities and see if he can, then he should be going for a brown fast. So it's all individualized decision according to the patient function class, comorbidities, and his own willpowers and resilience, all that. So appropriate advice regarding general measures and drug dosages and timing should be given. So if you are allowing someone to fast, then it's your responsibility to advise him the tailor-made and all the probable complication which can arise, signs of complication, and you should be in close contact to him to get advices if God forbid some, and try to bring a positive change in your life. That is again very important. So with that, I'm ending my presentation. I'm really thankful to the organizer for providing this opportunity to be part of this CME. And if any questions, I'll be there to answer. So thank you very much for your patience listening.